Welcome to Discover You, an inspiring podcast exploring cutting-edge solutions to our everyday psychological challenges. We explore complex mental health issues and talk to professionals, experts, and renowned authorities at the forefront of transformative healing. Our mission is to educate and destigmatize, and to ultimately view mental health as a proactive quest for optimized living and equilibrium, rather than mere crisis intervention. Welcome to another episode of Discover You, our podcast exploring innovative and effective solutions to challenges and issues that we're facing in the mental health arena. I'm Kalmenson, CEO of Montare Behavioral Health, a family of dynamic and comprehensive treatment centers in Southern California. I'm so honored to be able to introduce you to one of the most forward-thinking and preeminent experts at the juncture of healthcare legislation and business today, Harry Nelson. Harry has his pulse on the direction we're heading for policymakers, payers, and providers. The landscape of healthcare is fast changing, and I'm so looking forward to hearing your insights, Harry. Here's a little background. Harry Nelson is the co-founder and managing partner of Nelson Hardiman, the premier healthcare specialty law firm in Los Angeles. Beyond his legal expertise, Harry is known nationally as a best-selling author and a leader in healthcare-related startups, co-founding 5 in the last decade. Harry's thought and leadership in the healthcare and life sciences industry has driven many next-generation healthcare ideas and initiatives to realization, including telehealth and other modalities of digital health and behavioral health. So happy to have you with us today, Harry. I'd love to begin with, I'd love to hear about how you got into this space. What initially sparked your interest?
First, it's great to be with you. Yeah, I'm happy to share a little bit about the story of how I got so deep into addiction treatment and behavioral health. I started my career about 28 years ago in Chicago, mostly doing institutional work in healthcare, representing large teaching hospitals at universities. And when I came to California, around 2001, I shifted my practice to representing originally mostly doctors and mental health professionals who were in trouble with government agencies, with whether it was the medical board or the DEA or Medicare. And a lot of I was drawn when I started doing that work I was dealing with people who had gotten in trouble for allegations of fraud or for overprescribing. But I was personally very drawn to doctors who had gotten into issues with government agencies because of their own addictions, and particularly the ones who were on a recovery path were deeply inspiring to me, and they became close friends, and they sort of pulled me into the space in the early 2000s when it was still much sleepier than it is today. And I was both professionally, like they were kind of trusting me to guide them as they were moving into addiction treatment from health, the physician side. And they were also on a personal level. I really came to learn a lot about myself just from sort of the being, closely working with people in recovery and sort of really connecting with that. So at one point I actually I had the claim to fame of representing every doctor in Los Angeles or in Southern California who was part of the medical board's, at the time, diversion group of doctors who had these issues. What happened over time was that as the industry began to transform, I was really positioned because I had been working for years doing with addiction treatment when it was a much smaller space. And as it was really expanding rapidly, I knew a lot of, I sort of had the ready answers to what it should look like. And in some cases actually I had the government, the regulatory agencies asking me for my opinion about it. So I really saw that the space was developing, and I really felt a sense of mission about helping it grow in the right ways and helping make it safer, both for patients and for providers, making it, trying to do away with some of the confusion, whether it was on marketing issues, residents' rights, medication, kind of the interplay of housing and treatment. I had the privilege of giving advice both in California and around the country, and really living through this transformation. And I've tried to honor that sort of privileged position that I had by being a voice for for positive change, again, for both patients and providers since then.
That's pretty amazing. It almost reminds me of Churchill once said, there are people who are born into leadership roles, and then those who really are just put in a place in a time with circumstances that calls for it. And it's a truly beautiful gift that you provide to the community. And it definitely goes a very long way in maintaining and preserving the proper standards of the providers and ensuring that clients are getting their optimal care. But I'd love to ask you what the first question is. It is a recent phenomena that insurance companies are covering addiction treatment. And this has obviously led to a significant upsurge of treatment centers specializing in chemical dependency. In fact, I believe there are more than 14,000 in the United States, and that number continues to grow. Can you help us understand historically how this came about, and do you expect the trend to continue?
So I think historically, insurance coverage evolved in our modern insurance system starts after World War II in the 50s, 60s, and 70s. And throughout that time, even into the 80s and 90s, we saw very little coverage, very limited insurance coverage and government program coverage for addiction treatment. By the way, as also mental health. We saw coverage in the physician kind of professional services context. We saw limited government programs like the Medicaid program having outpatient groups. And most of the treatment program coverage only came through employer-sponsored plans at a relatively small number of employers. My take on what happened is that beginning with it's almost an outgrowth of the opioid crisis, is with the late 90s, with OxyContin getting everybody's attention as addictions were going up, hospitalizations for overdose and overdose deaths were going up. It started to catch people's attention that this system that we had was really failing us, and that there was the discrimination that existed between addiction treatment and mental health, behavioral health, relative to medical surgical care was really harming many, many people and frankly harming our system. And so we saw the first major shift begin in 2008 with the Federal Mental Health Parity and Addiction Equity Act. And that was a law that didn't cover every insurance plan in the country, but it was the first time that we actually had a law that said to health plans, and it was really focused on the employer-sponsored plans, that they couldn't discriminate. They weren't supposed to be discriminating, and we can talk more about this today, between the way that they treated insurance coverage for addiction treatment and mental health relative to medical surgical. So that was the first positive change. We're still waiting for that law to be enforced, but we can talk more about that. But then the other even more significant shift was just a couple years later in 2010, when we passed the Affordable Care Act. It was the first time that we mandated to every insurance company, government, employer-sponsored, commercial, small business, small employer, individual market. We told them what benefits had to be in the essential minimum package, and we included addiction in that. So that was the first time we had a affirmative mandate, and that was a game changer. And that's when we began to see the industry explode. And just to take the second half of your question, which was how are we going to see the growth continue? My belief is that we are living through a moment when addictive disorders are absolutely proliferating, and we are starting to wake up to just how deep and how broad this problem is in America. So I think the need is going to be there. We can talk more about it in the interview. The challenge is that what's also happening is this constant pressure from our healthcare system and from insurance companies to reduce to shift all care towards the lowest possible acuity setting. So essentially raising the standards on what it takes to justify inpatient care, residential care, and forcing everything to lower acuity settings. So the good news is there's going to be a lot more care. The bad news is that the standards keep changing on healthcare providers.
Yes, and that is definitely something that is disturbing, and we're seeing that on the ground as well as a provider. Before we unpack some of those details, just wanted to share that, for me personally, I got into the field because I do have a passion for helping people, and I find that my efforts are continuously thwarted by an insurance system that caters to large, unfeeling corporate providers who have no qualms denying treatment to people. The data clearly shows that the sooner people get into treatment and the longer the treatment lasts, the greater the chance of long-term recovery. Research studies published in the Psychiatry Journal, the American Journal of Drug and Alcohol Abuse, and copious research done by the NIDA, the National Institute on Drug Abuse, they all reinforce the same message. The longer folks are in treatment, the more effective the results will be. So as a provider, we're experiencing deep frustration and somewhat disturbing ethical dilemmas, finding ourselves frequently in the position of choosing between sustaining a business and not going bankrupt because of not being properly compensated by the insurers, and shuffling a client out of treatment before we feel clinically that it's appropriate and responsible. Are there any efforts afoot to change that system, to advocate on the people whose lives we're trying to save?
I think it is happening, but it's happening slowly. What I would say is that, so the mental health parity, addiction equity parity effort started in 2008, but here we are 13 years later, and we're still very much waiting for enforcement. The reality is that insurance companies don't actually live up to the obligations that the law imposes on them until they're forced to, either because they get sued by individuals or because government agencies come after them for penalties and for enforcement action. So it's a huge problem, and I think that we need more providers to focus on really pressuring plans to live up to their obligations. At the same time, I think it is important just to sort of talk about that broader trend that I alluded to a couple of minutes ago, which is the idea is that when it came to what we essentially did with the Affordable Care Act was we expanded dramatically not only who was covered by our healthcare system. We expanded, for example, the Medicaid program, but we also expanded the burdens that the insurance companies have. And what the insurance companies did in response is they're taking these new obligations that they have to provide coverage, and they're trying to control them because most of them are for-profit, and they're trying to preserve their profitability. And they do that by essentially raising the standards of what it takes to get paid. That's where this idea comes from that for example, that we have to constantly be putting pressure on providers to figure out the lowest acuity setting, right? Our hospital system has dealt with that. We've seen the hospitals no longer can take patients today that they could have taken 10 or 15 years ago and get paid for them. And we're seeing hospital at home, right? Or the surgical procedure that gets done in a day and then people are expected to convalesce at home. And so I think that same pressure is going to continue to be there. And the challenge for behavioral health providers is to figure out how to work in that system. So part of the answer is holding the feet of the insurance companies to the fire and making them live up to their obligations. But I think we would be remiss if we didn't acknowledge that there's also a fundamental challenge of adapting to how the system is changing, and recognizing that the bar is being shifted, and that the standards of what's going to justify a particular length of stay, for example, is going to be higher. It's going to take more demonstration of efficacy, of really good management, patient care management by the providers, and that's just unfortunately the reality of our system.
Yes, and I totally hear that and see that. I feel like at the heart of the issue, at the core of it, is really this erroneous notion that insurance companies are still identifying with, essentially that addiction is a choice and that it's not a disease. And so if a client or a patient has been to several treatment centers in the past year and is relapsing or has a reoccurrence of the disease, they are likely to be denied coverage for further treatment. And it's almost like a David-Goliath situation. Is there any legal recourse for smaller healthcare companies and organizations or for patients to advocate for themselves, whether it might come in the manifestation of a class action lawsuit or coalitions, to galvanize greater numbers of people just to come together and send a message that the stakes are incredibly high and that people are dying?
Yeah, so look, you're alluding to what I think are the critical pieces that are missing. It is not a level playing field. When you look at kind of what the laws that are being passed and how the laws are being enforced, you have many, many more lobbyists and dollars flowing from the insurance companies to pass laws that they want and to block laws they don't. The best example I can give you here in California is the pay to patient debacle, right? For many years we were trying to pass a law that required insurance companies to pay addiction treatment programs, because giving, the cash to somebody who's just newly in recovery from addiction, expecting them to take that money and give it to the treatment program, and when you're tempting them essentially by putting cash in their hands, is a terrible idea. And yet that's exactly what the insurance companies were doing. And every time we went to try to pass a law like that, the insurance companies would block us because they had more lobbyists, more dollars, and they just were able to fight it off. So we need the industry, both treatment providers and patients and families, definitely need to start really aggressively taking the fight to the level that the insurance companies do. And I think you alluded to lawsuits. So I think we've seen really powerful results coming from class actions that challenge the insurance companies on discriminatory standards, on really not, on paying lip service to meeting the sort of best practices on coverage, and then saying one thing and doing another. More sort of what we call mass actions, like group lawsuits by providers and by patients. And we need more lobbyists, and we need more efforts. I can't tell you how many times I've gone to the file in Sacramento to see what the letters in support and of opposition to bills that really affect addiction treatment are. And I've seen the anti-letters from the addiction treatment, from the insurance companies, and very few letters on the pro side from the addiction treatment community. I think we're only now waking up to the need to really put dollars and to put effort behind expressing how important this is. And I think the more people that participate in that, the more that legislators are hearing from people that this matters to them, the more that we'll see results.
Yes, that is encouraging. To draw it down for a moment, practically, I want to paint a certain scenario. So suppose a parent calls you up and tells you that they have a child who's looking to get treatment, and the child has expressed suicide ideation. But the insurance company says that if the child doesn't have a specific plan about how the child will execute the suicide ideation, they're not going to cover inpatient treatment. Is there a legal doctrine that says that a person must fail first before getting appropriate treatment? Is there any legal liability for the insurance company if the person is denied coverage for the needed treatment and then there is a fatal outcome?
So first of all, fail first. We've been fighting about fail first, literally going back to 2008. That was one of fail first. This idea that you have to fail on lower levels of care before you get to step up and actually get treated. For example, residential or inpatient is illegal. It is absolutely discriminatory. We don't make people who have blockages in their hearts fail first on wait till they try medication or something. We go in immediately and we clear up blockages, and we can't. And that's absolutely a discriminatory issue. One of the challenges is that the government, when we wrote when the federal mental health parity law was written, we didn't allow individuals to sue under it. We left it strictly. There's no private right of action, meaning we have to count on government to enforce it, which really has not happened anywhere close to what we'd like to see. So the answer to whether there's a basis to sue the insurance company really depends state to state. And the advice I would give any family that's dealing with this is, you need to sort of scream from the rooftops. You need to get the story out there into the media to embarrass and pressure insurance companies to do the right thing. And it's very, very important to enlist doctors to make the case for medical necessity and to make complaints to government agencies to actually get action. It's a terrible situation we're in. Even today, I heard a story of a girl experiencing suicidal ideation who was kicked out by after a 14-day stay by one of the large payers here in Southern California, and actually harmed herself. And it was, after protest after protest by the parents, by the provider. So this is very much a live issue, and providers need to be really fighting, and families need to be fighting, and getting these stories out there so that people hear what happens when payers just cruelly cut off care.
Absolutely. Is there any non-legal coalitions that parents can be a part of to make their voice heard? Are there any sort of practical type of initiatives that are in existence that our listeners or viewers, would benefit from? That you're
I didn't bring. I'm happy after this podcast to sort of circulate a list of organizations that are doing a particularly good job. There's a number of nonprofits who are out there. I frankly think we need more. I will say that here in California, the California Consortium of Addiction Programs and Professionals has been slowly building organizations for families and for parents, right? And for the addiction recovery world. And we need more cooperation. There's been too much, frankly, from my perspective, there's been too much sort of turf wars between various addiction treatment advocacy organizations. And we just need more cooperation. And every organization can have its own particular focus, but we need more collaboration to really make this a voice that's heard loudly, both at the national level and at state by state level.
And it makes sense. It goes without saying that there is a tremendous power and strength in numbers. I want to, for a moment, move the discussion away from the insurance companies and talk about the current climate in the industry as far as the providers are concerned. What recommendations would you have for treatment centers to implement as best practices?
So the big thing that I see that's really sort of frustrating for me is that a lot of the landscape is really shifting. We've been making this gradual move into what we call a value-based care world, meaning that over time, what we're seeing is that essentially we're looking for more shifting of risk to the provider level, more emphasis on really establishing clear best practices, shared savings, and opportunity for providers who can deliver care efficiently and really get good outcomes. And I don't see the addiction treatment community and behavioral health community really fully adapting to this. I think it's if any part of our system is kind of lagging a little bit, it's been in behavioral health. And so to me, the key things that providers need to be focusing on are the steps that get you into that world. And it starts with moving into an interoperable record set where your records are able to be shared with other healthcare providers. We're still a few years out from the point where the same record will be shared by the addiction treatment program and the doctor, a mental health professional, a hospital if one's involved. But we want to create that 360-degree view, and it starts with interoperable records. It also starts with really taking a specific look at each patient and not having kind of a cookie cutter set of records, and dealing with really the specific issues of the patient. And I would say that it's very important to actually be maintaining data on how your program is doing, on your effectiveness, right? We haven't really seen the industry do a good job of producing long-term studies of results. And that's not a burden on any one provider, but we need more of that and focusing on effectiveness. So I think that's one side of it. And then the other advice I would like to see is more differentiation into dealing with specific issues, because I think it's very, very hard for patients and families to figure out where their relative or their loved one should be, or for people to find for themselves. And I think we need to do a better job of saying our program really focuses on this cohort or this modality of care, and this is really where we excel. And I think the more that programs do that, the more that they will succeed. And then the last thing I'd say is addiction treatment also has some work to do to move more into the kind of compliance related environment. And compliance is kind of a dirty word to a lot of people. Just sort of see it as a necessary evil to have policies and procedures. I really think that, doing more to focus on the risk issues where your facility could be doing better, whether it's on documentation, whether it's patient care, whether it's safety issues, whether it's privacy, is at continuously being in this process of quality improvement, training the workforce, and just sort of checking in on how you're doing and building that into the fabric of your program is, to me, so important. And that's another area where I'd love to see providers doing better.
Thank you. That was very, very insightful. To draw it down for a moment into an elevator pitch, I guess my question would be, what would you tell a parent, a relative, or a friend of a loved one seeking an addiction treatment center? What would you guide them and advise them to look for? 3, 4, 5 things to look for, which would be accurate indicators of a quality provider, a quality program?
Sure. So, it's not only one thing, but I would say, you really, I would go back to a couple of the things I just said. I think it's important to really understand if the program that you're looking at has a specialization and not take a kind of one size fits all approach. I want to know who else is going to be at that facility in terms of the cohort. Like if I'm sending my teenage daughter to the program, I want to know, that she's going to be with people in the same situation, right? And one of the things that to me is most important is clinical integration, meaning whether it's a residential program or an outpatient program. Who are the doctors? Who are the mental health professionals who are providing care? To me, you want to have an integrated approach in the same, in the way that everything's being managed, as opposed to sort of a separated, siloed approach. So that's something I want to know is the program doing that? If they have records of how they're, of their past performance, I'd like to know about those. I want to know. I often sort of look for a few warning signs. One, you alluded to this question of what happens when the insurance company stops paying. I particularly see it as you have to be careful. I want to be careful in how I say this. I always urge, treatment programs that they have to focus on everybody that they're taking care of, and they shouldn't put themselves in harm's way financially by overextending themselves. At the same time, there are lots of cases where the insurance hits a snag or stops, and I'm interested in programs that are going to really, work with families and patients and not just be quick to pull the plug and send somebody out. And finally, I want to know, on the ground, how, I appreciate transparency about how long the staff has been there, programs that are struggling with turnover, and programs that are actually, really working on some of the challenges that we see on the ground, whether it's residents' rights issues, just thoroughness. And I appreciate programs that are transparent.
Absolutely. The next topic I would love to get your take on is a topic that is near and dear your heart, and you're a very forceful leader in that, and that is telehealth. Telehealth is becoming increasingly relevant and is becoming an enormous tool in behavioral health. So technically, what does the Parity Act or Obamacare say in regards to telehealth? Is it something that is mandated in terms of providing coverage for? And then I would like to get your take as well on practically, in your opinion, is it as effective as in-person treatment? And how do we advocate for insurance? Yeah. Go ahead.
I'm not a clinician, so I'm going to stay away from. I can't really comment on is it as effective. I think there's no question that the experience of being, in an intensive setting and a higher acuity setting, being in a residential setting, is always going to be different than being on a computer screen, right? We're doing this interview virtually, and I wouldn't have tripped over you and asking the question a minute ago had we been in the same room, right? So there's really, we make an impact on each other. There's no question by being in person, and I think for people who can afford to make that, or who can get their insurance companies to pay for in-person care, let me be really clear. I think that is always going to be the highest and best choice. At the same time, what excites me about telehealth is that, it offers an option. Not everybody has the ability to pick up and move their lives right to do a residential or an inpatient program. And sometimes it's work. It can be there can be all kinds of reasons why it doesn't work for everybody. And my feeling is we want to have as many pathways, as many roads to recovery as possible. And telehealth is an important one. Now, to your question about is it required? The original Mental Health Parity Act in 2008 didn't talk about telehealth. We've seen over the last 15 years, many states enacting telehealth parity laws. They've kind of come in waves because the first issue is, can providers use telehealth? And we have most states have passed some version of a law that says you can use telehealth. But then the question, of course, is how do they pay for it? And many of those states, insurance companies won't pay for it. Providers are allowed to do it, but they won't necessarily get paid for it. So we've been seeing a handful of states. I think California was number 12 when it passed this last year, that passed a reimbursement parity law. And that was a good law because it was basically it provided that insurance companies are required to pay on the same basis and to the same extent that they cover in-person services, meaning they can't just set a completely different set of rates. Of course, that was only limited to in-network, and it still said insurance companies can, negotiate and bargain for lower rates. And it doesn't help the out-of-network folks. So we still have more work to do. I think that telehealth, we've been seeing a progressive year-over-year expansion of telehealth options. I work with a handful of recovery, of addiction treatment providers and mental health providers that are really sort of pioneering in telehealth. And I think it's really exciting. It's not, again, I don't think it just substitutes or takes the place of in-person and residential. I just think it's another really great option out there. And so the question is, how do we make sure that we have access to all forms of treatment, and how do we ensure that more providers have access to participate in telehealth, even if they're not in network? I think we need more changes in the laws to drive it, but I'm excited. I think the telehealth has really dramatically exploded in its usage and its growth during the pandemic, and I see that continuing. And I think that's going to be one of those real growth spots that I would encourage addiction treatment providers and behavioral health providers generally to be thinking about how they can play in a telehealth world. And by the way, I think it's a great way to extend the relationship when a patient a patient may be on site, inpatient or residential, or outpatient, but it's still a way to stay in touch with people and continue the relationship longer over time, which we know really is a major differentiator in success.
Thank you for that insight. I want to ask you a little bit of a curious question, and not as much a practical one. It seems to me to make a lot more fiscal sense for insurers to authorize longer and more thorough treatment protocols, which have a much greater chance of success than severely limiting the coverage up front. Inadequate treatment leads to patients relapsing repeatedly. Why are the insurance companies seemingly taking a position that doesn't sound logical if they could take a more strategic approach and overall reduce the relapse rates, help out their population, their consumers, their clientele? Win-win.
So look, I'm a provider side lawyer. I spend some time with patients, relatively little time advising payers. So my take is, look, I agree with you. We would be much better to have insurance companies just focusing more on really good protocols, but covering people for care for the amount of time they need to really give them a good foundation. I think the problem is that the insurance companies have been scrambling. They've been kind of playing off of their back foot. That's especially since the Affordable Care Act, even though it sounds funny to say that 13 years later, it's still, they're still scrambling around. I think they are really working hard and struggling to figure out how to manage effectively, how to differentiate better and worse providers and patients who need longer and shorter. And I think what happens is they end up finding it easier to just apply really broad brush rules to control costs. And I remember in the early years after the Affordable Care Act, I heard that we have 6 major health plans that dominate California. One of them had lost almost $1 billion in the first year that the mandates went into place, whereas others had done very well. And of course, that corresponded to more care and less care. So unfortunately, I think what's happening is the health plans are really focused on their own financial viability. If they are for profit, their returns to their shareholders, and we're seeing these really arbitrary cutoffs. And I think we need to make the case both to the insurance companies directly and to the regulatory agencies that manage them and that are supposed to manage and oversee them, that we really need to just have a focus on providers, on demonstrating that providers are doing the right things, and then covering people for long enough to actually let the people have a better shot, because no one's being helped in a system where there's a revolving door and people aren't getting to a level they need to be to sustain recovery post-treatment.
Agreed. Last but not least, I'd love to hear your thoughts on what's on the horizon legislatively and how healthcare is likely to change as a result. And then to leave you off with a fun one, if you did have a magical wand, if Harry Nelson had a magic wand, what would that magic wand do to the industry, to behavioral health in an ideal scenario?
So I do think legislatively we're seeing progress. A lot of focus this year on getting rid of some of the bad practices in marketing. A couple of years ago, we were going after kickbacks, right? We had the federal major eliminating kickbacks in recovery. I think that we've now put into place laws that really address that issue. And what we're seeing is more of a focus on kind of some abusive marketing practices by call centers that are trolling on other program identities. And I think part of the issue is that many families will, for example, go to the internet and look for a program, and they'll find websites or phone numbers, and they think they're talking to a treatment program, and they're really talking to a marketer who is intermediating and essentially trying to direct their business to treatment centers. So we're seeing a whole rise of state laws, and California passed a version of it to get rid of those kind of that particular kind of what I'll call intermediating call centers or digital lead generation. We're also seeing a lot of laws changing standards. California just came out with a very specific law of the kind of insurance coverage that's required. I think we're going to see more parity laws. We're going to see more and more standards. But let me shift over to kind of my wish list, because a lot of this is where I think we need to be focusing our energy of what I would like to see in terms of legal changes. At the top of my list is we need to really see money flowing into recovery housing, recovery coaching, and more recovery support services post-treatment. We don't treat any of that as part of treatment. We treat recovery housing as sort of something that the recovery community and people who need it have to figure out on their own. And we really need that absence is really creating a lot of harm. I would like to see funding nationally really expand that. And there's talk of that, but we really got to see action. At the same time, hand in hand with that, I would like to see clear standards set up for recovery residences and uniformity of standards. And by the way, uniformity is that word is going to come up a lot. If I'm running a hospital or a nursing home or a home health agency in one state and I want to go into a different state, the laws look pretty much the same, but we need uniformity from state to state across outpatient care and residential, across all levels of care. It's really frustrating how confusing and how different the law is from state to state. I would like to see significant more funding, government funding on evidence-based practices for effective treatment, for effective detox, and laws that hand in hand with that force insurance companies to actually to contract with and pay out of network programs that are meeting those standards. One of my pet issues, I really want to see decriminalization of therapies, potential therapeutic modalities that could be enormously helpful in treating, in detox, or in accompanying mental health issues and post-traumatic stress. Things like Ibogaine, which has been shown to have dramatic results. For example, in treating in detox from heroin, I really would like to see more psychedelic research and access, which we don't have under the current Controlled Substances Act. I would like to see this. One of my pet issues that drives me crazy is the focus on patient financial responsibility, patient deductibles, and co-insurance. And those are tools that insurance companies use to basically, they call it a utilization control. It's there to make sure that patients are not overutilizing and that they have financial sort of skin in the game. But given what addiction does to people's finances, both to the person experiencing it and their family, it is just an outrage that those requirements are being used by insurance companies. And I would like to see laws in every state that recognize that addiction treatment programs can grant financial hardship discounts and should not be forced to apply deductibles and co-insurance in a way that impedes treatment. And then I'd like to see more. I know I've got a lot of things on my list, so I apologize, but just a couple others. I mentioned earlier this siloing of the professional side of treatment, physician services, psychiatric services, or other mental health professional services, and treatment programs. I'd like to see laws that allow for more integration. It's bizarre that we have laws that actually make that harder. For example, here in California, it is technically, there's no legal way that a physician and an outpatient program can work in tandem. And it's only a few years ago that we actually created one pathway for physicians to come in and provide incidental medical services in residential care. On a very big level, I'd like to see a national conversation about the way that so many people are still being blocked from getting the help they need by shame. I think we need to have a different kind of public conversation. And if I had a last item on my wish list, it would be going back to a theme we've talked about on this podcast. We need more laws for private rights of action to allow people to sue insurance companies and force change. Laws just don't change behavior by themselves. It's really about enforcement of those laws. And when you look at states, California, like many states, has a law. If a senior gets mistreated in a facility, the lawyers who bring those cases can get attorney's fees, and that forces good behavior by senior care facilities. We see that in the employer market. If an employee sues for being mistreated, the threat of those lawsuits changes behavior. But we don't see anything parallel for insurance companies in behavioral health and addiction treatment, and more generally. And if we want to see real movement by insurance companies, we need to empower people to make full use of our legal system and to take them into court and challenge the bad behavior. So I'll stop there, but I know it was a long list, but if you're giving me a magic wand, that's what I'm doing.
Wow. Thank you so much for that, Harry. And thank you really for joining us on the Discover You podcast. We so appreciate you sharing your time and expertise with us. And thank you, audience, for joining us. You're not alone on this journey. For inspiration, find us at Montare Behavioral Health on YouTube, Facebook, Instagram, and the web. Wishing all of you great health. See you next time.